A 15-year-old male presents with progressive shoulder pain. I'm showing you the anteroposterior and axial radiographs of the shoulder. Describe the findings.
All right, let's take a look. The radiographs of the shoulder demonstrate a well-defined lytic lesion in the proximal humeral epiphysis. The lesion is characterized by a central lucency and a thick surrounding sclerotic border with a narrow zone of transition. Crucially, the proximal humeral physis remains open and unfused. There is no evidence of aggressive periosteal reaction, cortical breakthrough, or an associated soft tissue mass. In a young patient with an open growth plate, this well-defined epiphyseal lytic lesion with a sclerotic margin is highly characteristic of a chondroblastoma.
What is the differential diagnosis for an epiphyseal lytic bone lesion in a young patient, and how do we distinguish between the main options?
The differential diagnosis for an epiphyseal lytic lesion is relatively short, primarily consisting of chondroblastoma, giant cell tumor, subchondral cyst or geode, infection, and less commonly metastases or myeloma. We can differentiate chondroblastoma from a giant cell tumor by evaluating skeletal maturity. Chondroblastomas characteristically occur in children and adolescents with open epiphyses, whereas giant cell tumors are almost exclusively seen in adults after the growth plates have fused. Additionally, giant cell tumors typically lack a sclerotic margin and are eccentric, whereas chondroblastomas frequently exhibit a thick sclerotic rim and internal matrix calcification.
I am showing you comparison radiographs and magnetic resonance images of other epiphyseal lesions. Describe the findings and how they assist in differentiation.
The comparison plane radiograph of the tibia demonstrates a well-defined epiphyseal lucency, while the corresponding T2-weighted axial magnetic resonance image shows a hypointense epiphyseal lesion surrounded by extensive hyperintense bone marrow edema throughout the tibial plateau. This reactive marrow edema is a classic hallmark of chondroblastoma and can sometimes lead to an overestimation of the tumor's aggressiveness on MRI. The last radiograph demonstrates a subarticular eccentric lucent lesion in the distal femur abutting the joint surface without any marginal sclerosis, which is classic for a giant cell tumor in a mature skeleton.
Explain the pathology and typical clinical presentation of chondroblastoma.
Chondroblastoma is a rare, benign, cartilage-forming neoplasm derived from immature chondroblasts. It classically arises within the epiphyseal or apophyseal centers of long tubular bones, most commonly around the knee and the shoulder. Patients are typically under 30 years of age, with a male predilection, and present with insidious, localized joint pain, limited range of motion, and occasionally a joint effusion. Histologically, it is characterized by sheets of chondroblasts with a cobblestone appearance and focal areas of calcification surrounding individual cells, often described as a chicken wire calcification pattern.
How would you manage this patient as a radiologist?
As a radiologist, I would recommend comparing these radiographs with any prior shoulder films to evaluate the lesion's growth. I would recommend a dedicated MRI of the shoulder to characterize the internal matrix, check for any cortical breach, and evaluate the degree of reactive bone marrow edema or joint effusion. I would communicate the finding of a benign but locally aggressive epiphyseal lesion to the referring clinician. Finally, I would suggest referral to orthopedic surgery for definitive management with curettage and bone grafting.